Okay. All right, folks. Just a little disclaimer here for this episode. While we were going to originally do about the financial mistakes and good financial decisions, this actually proceeded into a long discussion about early thinking skills, particularly as you're a new attending. A lot of important information, a lot of things about understanding, confidence, and care. What ways to think about what you should be doing, especially earlier in your career. So a great episode, but this has nothing to do with finances. So on with the show. Hey, folks, welcome back to another episode of the Change Physician Podcast. This is your host, Dr. Kevin Cuccaro, with my amazing co-host, Dr. Melissa Cady. And for today's episode, this one will be for the new grads here. And we're going to talk about the 3 best and the 3 worst financial mistakes that we made, or perhaps we have heard of, when we entered our early attendingship. I guess that's what I don't even know what you call it. You leave residency.
Yeah.
Doesn't have anything cool. We'll just say attending, yeah, or whatever. So how's that sound for you?
That sounds good. Actually, it reminds me of like when you become a consultant in like Australia or New Zealand, you're like officially no longer in training, so to speak.
No longer in training, yeah.
Although we're really always learning, so don't kid yourself. You're not.
Well, yeah. A different phase of learning.
Yes. Yeah. Yes. You finally have to rely on your own resources to find the answer.
Or we can even imply is you're ultimately the one who's responsible.
Yes.
That's one of the things that's always kind of interesting about residency, and we take ownership or whatever. But I know for myself, that was the profound difference between a resident. There was always somebody else, right? Yes. There was always somebody else who was somewhat responsible. And as an attending is you. It's really all under your purview.
Right. And that's the scariest thing when you go out on your own. It's like, ironically, it's like you may feel a little more confident and you can do things and prove to people you can do things. You don't need anybody, but you really have someone there to like take responsibility, which gives you sometimes this little extra boost of confidence. But the moment you have that feeling of you're naked and nobody is there to like, although you can, lean on colleagues and friends and help you out, but in the moment you are ultimately responsible. That is when you really grow up.
Yeah, no, I completely agree. And I'm just laughing because I'm thinking about things that I said as a medical student, then as a intern, and as a resident, and a lot of confidence. I would say false confidence, but I felt really confident, but it was because it was not me. Ultimately it wasn't me who would bear the brunt of the responsibility for the decision.
Yeah.
So yeah, that's a interesting thing.
I have to say off of that, it just made me think of that little false confidence and how this impression of medicine is that it's so black and white, and that once you know something, you know the answer and you know how to deal with it. But there's so much gray that's part of the art of the medicine. And when I hear friends or family say, oh, this friend had a diagnosis of this and what do you think? And then they're like, I just looked this up, and like now they know, like they read about it and now they know everything they need to know about it. It's like, don't have that kind of confidence, because there's always, it's not all or nothing. It's not that black and white. So anyway.
Well, no, but that's an excellent point, because particularly in the rise of the internet era or whatever, in Google, and everybody, we sometimes in the physician community, we scorn it. We call it Dr. Google or whatever. And it's actually a amazing tool. So I don't ever want to take away the power of information, but what I kind of think about our training in the purpose of being a physician, that whole breadth of knowledge that seems oftentimes to get downplayed. And we're not going to get in the politics of it, but oftentimes downplayed. What that teaches you really is to recognize what you don't know. I always think about, there's this little circle. When you have this little teeny circle, the surface area of the things that you know, or actually say, so the surface area of the things that you don't know is pretty small. But you know this stuff in this little teeny circle, and you're like, oh, that's the whole world. Yeah. But it's like medical school, you're like, whoa, this is bigger. And it keeps getting bigger, and it keeps getting bigger. And that surface area just is, all of a sudden you're like, holy crap, there's so much I don't know.
Yeah.
And like you were saying, is oftentimes I'll see people with more education being much more hesitant and being able to say, well, maybe, and to question things a little bit more. And rather than this, I know it's the fact, I know Google says it's this, I saw it one time in my life, and so I know that this is the same thing. yeah, anyway, I just firmly really believe this. The more educated you are, the more exposure, the more training you have, the more you start getting this humility about there's a whole lot of crap that I don't understand as well as I should, or that I didn't even think of before.
Right. And that's the irony, is that then suddenly when you get to that place as a physician and then you try to help patients understand that it's not a definitive answer or a definitive treatment, and sometimes just some little bit more clear cut, but when there's some hesitancy and it's kind of like an educated guess, this is what it could be, but it may not be, or this may work or this may not work. People don't want to hear that. And so there's that dynamic where you like want to express confidence that you can potentially help them, but it doesn't mean you always have the perfect answer at that moment, and it can be a process and not necessarily this immediate gratification that they may want. But
and that's the balancing act of being a new attending.
Yeah.
Right. Because the other thing is that you need to recognize is someone's coming into you, they do not want somebody who's not confident. Right. Like, you come into your doctor and, the default is you come in attending, and then you're like, sort of like, oh, I don't, there's so many things I can't make it a definitive decision. And then you got somebody in front of you who's like, what am I supposed to do, doc? And then you're like, well, I don't know. That does not make people happy at all. So then you're in this balancing act of, well, how do you present your information confidently and competently enough that people trust you, while in the same way not going on that other precipice of overwhelming false confidence,
right,
where, oh, I'm completely correct. And that I think is the game of being a good attending, is when you can start doing that fine line, and you can be a good doctor. And I can't remember who I was talking about this with, but I think that really comes down to is being able to decide, like, you can't know everything, but if you recognize what you don't know, what we're really trying to do in that balancing act is to recognize what we know that are the horrible bad things. And if we can exclude those, and we can confidently exclude those, we still may not know every other detail there, but you can provide a greater sense of assurance and not fall into that trap of false confidence, or, that definitive answer of I know everything and it's just one thing or whatever. Does that sort of make sense?
Yeah, I think, sometimes people want guarantees, but I think physicians fall prey to that at times. And then when the patient doesn't get better, they get ticked off. So I think part of our job is to express the confidence that there is sometimes what we perceive based on the current information, that this might be what's going on, or this might help, that there's a possibility it could be some other things, but we won't know till we kind of like, let time go by, or see how things go, or see if this helps. And so I think expressing confidence in the fact that there is some variability, or confidence in the fact that things aren't always black and white, and like kind of expressing that in the way that you converse with the patient, that if this doesn't get better because this, it's because maybe some other things, and we'll definitely dive into some more things and reassess things. So I think if you kind of create this uncertainty, that you're confident that there is some uncertainty in medicine, but you're portraying in a way that there's still ways that we can kind of like work with it. I think that's kind of where we're coming from. And I know it seemed like we went on a tangent from what we're about to talk about, but I think actually this plays in perfectly, because it's all about perspective. So
I was just like, we should just stick going with this, and we'll do a next episode on the financial thing. And this will be, you can label this one false starts, the false start.
Hey, well, then go ahead, keep it running. Let's do it.
Because I think this is an important topic. And we were presenting, I was like, okay, well, the financial information for new residents, but this is sort of, this actually impacts, I think, physicians throughout the spectrum, is, treating confidently, competently, being able to communicate effectively, not falling into that sense of of false or overwhelming ignorant confidence, where you just don't know enough to not know what you don't know. And it is such a this exquisite balancing act. And the thing I'm kind of remembering, my brain, I think, tends to work a lot differently about this stuff, probably because I'm a pain doc. And so we're dealing in this realm of such a complex thing when it comes to pain. And when it comes to pain and people are saying, well, tell me the cause. And I really, really recommend people move away from that and say, well, just tell me what isn't contributing, right? So, and as a physician, I can do that. I can say, I know it's not a broken bone. I know this is not an infectious process. I know you don't have an autoimmune disease or some sort of neuromuscular condition. I'm not thinking that you have some other weird zebra etiology based on what you've told me and what my physical exam shows. I'm really confident in what I know isn't contributing to your pain. But we have this whole complex process here. And if I don't know what the cause per se is, and I don't know exactly why you're hurting. I know you're actually hurting, but if we can exclude all that bad stuff, then we can take the next step. And for other clinical disciplines that, although pain is universal, like that's the thing that always drives me crazy about physicians. Oh, I don't have to talk about pain. Well, if you see patients, they're going to talk to somebody about pain. Yeah. Sorry. But you go down to, okay, well, what's the easy stuff? Is a broken bone. That's pretty easy to rule out or rule in, right? And if you can do that simple step, you can be really, really confident about that. Everything else downstream, as those processes start to get more and more complex, that becomes more difficult. But as a physician, if we can start eliminating all the simple stuff, the broken bones, the infections, the things that we're really good at, that's a pretty good step. And then being able to communicate that to your patient saying, well, I thought about all these bad things based on the facts, the evidence, and objective data. We don't have to be concerned about that. Now it's just beholden on the physician to understand those other complex processes like pain and other symptoms that are intertwined with the human experience. And if you can then kind of navigate that and kind of, then you can become a really, really good doctor. So
yeah,
went all over the place there, starting with confidence and false confidence and knowledge and into this idea of excluding really those bad things, which are usually the easiest things to do.
Yeah.
I don't know. Makes good docs.
Yeah. Well, and it makes me think of a couple things. So by if you ask the patient, what is it that concerns you the most? Sometimes that helps you kind of figure out how to direct or explain or give them some confidence about some things. And then you can really address the reason they're there. First of all, I mean, they don't just come to you just for the fun of spending money or anything like that. I mean, there's a legit reason, concern, or something that they're, some anxiety or fear, or just annoying as hell, and they just want someone to help them out or don't understand it. But I had an interesting interaction with someone I've been coaching, and just generally speaking, they have tried everything as far as how people define it, like injections and medications and everything else, and was
all the passive stuff.
Oh yeah, a lot of passive stuff, and then has gone to a couple surgeons, and of course the surgeon is saying, well, you've obviously tried everything, and yet there was some interruption. I guess they found somebody said something about what I had said or wrote, and then they're like, hold on, wait a minute, this is contradicting what the surgeon said. And essentially they interpreted, well, why would the surgeon tell me I've tried everything, so the next thing is surgery, when I don't have all the indications that make sense for having surgery? If I just have pain and no like other radiating symptoms or, muscle atrophy and like, neurological concerns. And that's really hard to try to get people to wrap their head around why our industry would do that. And unfortunately, it's just based on limitation of their own education, and they're trained to do surgery and they don't have anything else to offer. And they haven't sent any other resources to consider other things. So the perspective, speaking of perspective again, it gets narrowed by sometimes people within the medical field that offer to a patient who gets really confused and is desperate for relief. And it's really hard to help them understand why they're not getting better. And yet this other person says the last thing left to do is surgery. So it can be a really challenging situation for patients. That sounds like a very negative thing to bring up, but it seems like this is a caught between a rock and a hard place. A lot of patients, either the pain of surgery, they don't know if it's going to help, but yet someone else promises it should be able to help if nothing else did. And yet they have the pain of their own experience. So any thoughts about that?
Yeah, actually, because you return it back to like a new physician, like in your new attending role, right? So that's the default, is if you have a couple tools in your toolbox, you're going to want to use them. If you're coming from this view that of I fix people, and they're coming to me for expecting to do something, then you're going to be more on more likely to default to the doing something than the not doing something. Oh, they're in distress, I need to do something. When we know, I mean, we've had talks about this both on the show and off the show about that's not a great viewpoint to have. And so what I would recommend for a new physician is to really understand what are the indications for what you do. Mm-hmm. And be comfortable then, if those indications are not met, be very, if you're going to start blurring those boundaries, that's where you're going to want to expand your learning a little bit more, right? And understand that that's okay. If particularly as a new, there's a lot of growth that you can do there, but there's a reason that we have indications. There's reasons that we have guidelines. It's not because we just make this stuff up. We're supposed to be scientists at the same time that we're physicians, and we're supposed to trust that data. And this comes, anyway. So I think as a new attending, if you had any recommendations to this, don't avoid the sense of false confidence, but be able to confidently exclude bad things. Recognize what the limitations are and the indications for your specific tool set, and be comfortable and confident about those. And then also recognize that even if someone comes into your office, doing something just to do something can actually cause more harm in a lot of those. And we don't even talk about the communication issues like you're experiencing, where now you have people getting all these mixed messages. And now who have we ultimately helped? We haven't. We've actually harmed people now just through that poor communication. I think you brought up a lot of complex things there that is sort of juggling that piece. And because you're also, where this is the fine line. Well, who's the bad physician? There are bad physicians out there, but I would also wager that most of them are not. I would say what we tend to do is we're almost killing people by thinking that we must do something, and recognizing that the doing something mindset can actually cause significant harm to individuals. We're not upholding any sort of physician oath by doing that.
Yeah. You just gave me a quote in my head, and I'm curious what you think about it. But misinformation does not equate to compassion.
Oh, absolutely. Totally.
Or intentional. I don't know if you call it whether it's intentional or unintentional. Misinformation does not equate to compassion if it puts patients at risk. Mm-hmm. So anyway, that was
that's a great point though too, because look at the words that harm, right? Actually, there was a great JAMA article, I should dig it up and pull it up, that talked about nocebo in the languaging, and there was a quote in there because what they were looking is statins, right? And so the wording and messaging around statins, and we know that how we frame something and how we discuss something influences the side effect profile of things. And people, placebo, nocebo, there's a biological reason for all this stuff to occur. But what they were finding with the study on statins is that nocebo response was huge, like massive, what people were experiencing with statins. So much so that one of the publishers was like, it seems like the vast majority of side effects with these statin medications are nocebic, that we're creating them. And of course, then you had someone in the commentary, they were talking about the articles. Well, I don't believe that. And it just made me want to reach through and smack them in the face. It's like, that's great. Your beliefs can go about all sorts, you can believe in God, you can believe in this stuff, you can believe in all these other things. But when it comes to something like this, where we have data, if you are going to believe adverse to the data, then you need to have data to back it up.
Yeah.
And you can talk about false confidence is, wah.
They don't want to hear it. That's
I couldn't even, this is like not even some of this is statins as compared to some of the more complex things. Let's not even talk about opioids. If you want to really get into something that has, firestorms and brimstones and all sorts of stuff coming out. But man, just relax and say, maybe I should read this study 3 more times. Maybe I should think about my patients, because I think it was a cardiologist at one of these ivory tower things, goes both of them were. And maybe I should just take a little bit of humility to recognize that there's probably something going on here that I need to understand better and step back. So new physicians out there, new attendings, man, maintain that humility, recognize, just be willing to question a little bit more about when the stuff comes in.
Yeah. Lego the ego.
Lego the ego. I like that. That's very cool. That's very cool.
If you remember what Legos are.
Man, how can anybody not know what Lego is?
Well, there are some people that they may not have any processed foods ever, and they just don't
not do Legos, which is like the greatest toy of all time. Yeah.
Oh, I was thinking Lego my ego.
Oh, geez.
Like waffles.
That's the other Lego.
Yeah, that's a different.
See where my brain goes.
Yeah, a little contraction there of let go.
Yeah.
But yes, Legos. Yes, that works too.
Anyway.
Yeah. So I think that was. I think we transitioned this conversation into, I think, a really important topic that many of us. Most of this is internal, we're dealing with in our head, but it manifests in ways that impacts our patients and their overall health and their safety. So I'm glad we touch on this topic. We might need to add a little front end waiver or disclaimer that this is actually going to be about this.
I'll start here.
Yeah, it's all good. But unless you want to tap it any further, we can trail off on this topic.
I think this is a good place to end. We could talk about, there's a lot of other things we could talk about that, but we'll save those for future episodes. Why don't you take us out there, Dr. Katie?
All right. Well, we left you some things to ponder here at the Change Physician podcast. I'm Melissa Katie with my co-host, Dr. Kevin Cuccaro. And if you have not checked out thechangephysician.com, make sure to check it out and sign up to be part of our community. And whether or not you're a physician or not, if you want to consider yourself an ally as part of this effort to really just instill overall wellness within physicians and have the mindset, strategies, and skill sets to lead a more fulfilling life and career, definitely join us. And we look forward to you being part of the community. And we'll see you next time. Take care.
Take care, folks.